So one of the important things that comes up in the MEQ is your understanding of the dopaminergic and serotonergic depression. At least two questions have come up in relation to two themes. And if you look at this particular diagram, what you can see is the frontal lobe side, the frontal lobe aspect, where predominantly the dopaminergic pathways are. The dopaminergic pathways come from the basal ganglia, the subcortical area, connecting to the frontal lobe. And you can see those areas are responsible for concentration, pleasure, psychomotor fatigue, and then lower down in the orbitofrontal you have guilt, suicidality, worthlessness, of course mood. So these are sort of the dopaminergic pathways related to the melancholic type depression, the more severe form of depression. So it's important to keep in mind that when patients have severe anhedonia, psychomotor retardation, significant neurocognitive impairment, poor attention concentration, psychomotor slowing, guilt, suicidality, worthlessness, neurovegetative changes that often happen due to increased limbic activity, which we'll see in the next slide. So you get kind of an agitated depression. You have dopaminergic pathways involved, so broad spectrum antidepressants are required. So what they've done in the MEQ is sometimes given medications such as venlafaxine 150, nortriptyline 100, which is telling you that these doses are subtherapeutic. It's for you to recognize that these doses aren't sufficient in the severity of depression that they've mentioned. So just keep an eye out for that. And clinical practice is also very important. Guidelines suggest to do have a read of the RANZCP guidelines on the Psych Hub. Also, you can read unipolar versus bipolar depression on the Psych Hub and deconstructing depression. So those articles will give you an understanding of how to think about dopaminergic versus serotonergic depression. Physical fatigue is often present in the spinal cord area, and that's why chronic fatigue has a slightly different pathogenesis. Okay, so this slide is really to show you that when we think about the range of antidepressants, SNRI is a broad spectrum. NASA, which is mirtazapine, is broad spectrum at 45 and 60. At 30 milligrams and 15 milligrams, it's predominantly antihistaminergic and 5-HT2A, 5-HT2C, and 5-HT3 antagonist. You need to go above 30 to 45 and 60 if you want to get the alpha-2 presynaptic antagonism, which pushes dopamine in the frontal lobe. And then tricyclics, MAOs, NDRIs are broad spectrum or dopaminergic. Tricyclics and MAOs are really broad spectrum, both serotonergic, dopaminergic, noradrenergic. Agomelatine pushes dopamine in the frontal lobe, but also M1, M2 agonism, assisting with sleep. Vortioxetine is SSRI plus being a serotonin modulator. Its big advantage is the 5-HT7 antagonism, resulting in pro-cognitive effects. So these are the key points that you remember for medications, because you're kind of targeting the symptoms with the choice of the antidepressant. Important aspect in the manic symptoms, or even mixed features, is it's a limbic system activation. So what has to happen for a good balance is that your frontal cortex, your frontal lobe, has to inhibit your limbic system well. But if the mesolimbic pathway is excessively activated due to increased dopamine, your frontal lobe becomes exhausted and isn't able to inhibit the limbic system. And that's when you start getting everything driven from the limbic system, that entire spectrum, all the way to delusions, hallucinations, hypomania, mania, agitation, etc. Okay? And that's what hypomania, mania often is. You get the frontal lobe inhibition has just been lost because the limbic system's overwhelmed it. Often they'll have a crash later on, and that's because of the complete exhaustion. So one of the other things in mood disorders to think about is estrogen and thyroid. The hormonal aspects are very, very important. In males, testosterone. Estrogen related aspects are in perimenopausal, premenstrual dysphoric disorder, postmenopausal. Do think about hormones, hormonal supplementation. This is a specialized area. You can have, again, a listen on the Psych Hub to Professor Jayashree Kulkarni's lectures for more of this. Again, not a lot of this will be asked, but you've got to be able to rule out these abnormalities in certain age groups, gender. Furthermore, thyroid is really important. We know that thyroxine and T3 augmentation is an established augmentation strategy for the treatment of depression. In males, testosterone. The other estrogen aspect that's really important is polycystic ovarian syndrome, which results in kind of an inflammatory state along with estrogen dominance. And PCOS is an endophenotype of a bipolar trait. So often individuals with PCOS tend to have a cyclothymic kind of pattern. And estrogen thyroid is important because they both enhance the sensitivity of the dopamine serotonin receptors, so they allow the antidepressants to act more effectively.